In today's video, we will discuss everything you need to know about what causes jaundice in newborns. Here we will find out what is neonatal jaundice, 4 ways how jaundice occurs in a baby, when do you say it is physiological jaundice and when do you term it is pathological jaundice, how to differentiate between two, etiological types of pathological jaundice, what are common causes that lead to pathological jaundice. Does breastfeeding have any role to play in increasing or reducing jaundice? How bilirubin circulates inside a newborn baby. Direct bilirubin versus indirect bilirubin. How much serum bilirubin level necessitates treatment like phototherapy, exchange transfusion, etc. And lastly, 8 most common causes leading to neonatal jaundice. So let's get started. The most common clinical condition in a newborn that needs medical attention is jaundice. What is jaundice? Jaundice is nothing but yellow discoloration of skin, mucosa and sclera of eye, that is white portion of eyeball. This occurs due to deposition of an yellow pigment called bilirubin. What is neonatal jaundice or newborn jaundice? When jaundice occurs in a less than equals to 28-day-old baby, then it is called neonatal jaundice or jaundice in newborn. Unlike adults, jaundice is quite common in babies. Approximately 80% of all term babies and 100% of all preterm babies develop clinical jaundice few days after delivery. In most cases, jaundice is physiological and harmless, but in some cases of severe neonatal jaundice, serum bilirubin crosses critical level. Then it can damage brain, causing permanent neurological disability like cerebral palsy, seizure, deafness, etc., which are preventable if parents and physician have some basic knowledge about neonatal jaundice. Enterohepatic circulation of bilirubin. Bilirubin is a byproduct of hemoglobin metabolism. It is further conjugated in liver and excreted in bile. It comes out through gut and excreted out in stool. Some bilirubin, however, undergo deconjugation in intestine and get reabsorbed from gut. And then it enters into plasma or circulation, from where it goes to liver for further conjugation. 4 ways how jaundice occurs in a baby. Hyperbilirubinemia or jaundice happens when any of the following condition is there: increase RBC destruction or hemolysis, or decrease hepatic or liver clearance, or decrease excretion of bilirubin, or increase in enterohepatic circulation. When any condition will lead to one of these, then it manifests as jaundice. Types of jaundice. There are 2 types of jaundice. One is physiological jaundice, another is pathological jaundice. Physiological jaundice in newborn. What is physiological jaundice? Oftentimes, jaundice in newborn is simply a normal bodily phenomenon and it is harmless. This is called physiological jaundice. Features of physiological jaundice. Physiological jaundice accounts for around 75% of all newborn jaundice. This jaundice typically has onset between 24 to 72 hours, that is day 2 or day 3 of life. Serum bilirubin do not cross physiological limit, that is up to 12 mg per deciliter in term babies and 14 mg per deciliter in preterm baby. There are no other known causes of jaundice in a baby. Physiological jaundice usually do not necessitate any treatment, for example phototherapy, exchange transfusion, etc. However, baby should be monitored and observed for increase in icterus or any other abnormal signs. Course of physiological jaundice. In term baby, it starts at day 2 or day 3, peaks on day 4 or day 5 and comes down by day 10 of life. In preterm baby, physiological jaundice starts at day 2 or day 3, peaks around day 5 or day 7 and reduces by day 14 of life. for bilirubin level to reduce below 2 mg per deciliter may take up to 1 month of age. Caution. Physiological jaundice is harmless, however need to be cautious in preterm babies because these babies may develop complication at low threshold of bilirubin and needs prompt intervention even at lower bilirubin level. Pathological jaundice in newborn. What is pathological jaundice? Approximately 25% of all cases of jaundice in newborn are pathological. If jaundice in a baby fulfills any one or more out of the following criteria, then it is labeled as pathological jaundice. Jaundice appearing within 24 hours of life, or jaundice presenting at more than 2 weeks of life in term baby, or more than 3 weeks of life in a preterm baby. Rise of serum bilirubin is more than 5 mg per deciliter per day or more than 0.2 mg per deciliter per hour. Serum bilirubin at any time is more than 15 mg per deciliter. If jaundice stains palm and sole of a baby. Neonatal jaundice in a baby along with white or clay colored stool. High colored urine staining diaper or cloth. Direct serum bilirubin level more than 2 mg per deciliter or is more than 20% of total bilirubin. Associated signs of illness along with jaundice like lethargy, poor feeding, hypothermia, temperature instability, sick looking baby, etc. Signs of kernicterus like hypertonic limbs, opisthotonous retrocolic position, convulsions, etc. Any jaundice causing total serum bilirubin to rise above 95th percentile in R-specific and gestational age-specific nomogram. Serum bilirubin level more than 95th centile on R-specific and age-specific nomogram is called hyperbilirubinemia, which requires evaluation and prompt intervention. Direct bilirubin or conjugated bilirubin versus indirect bilirubin or unconjugated bilirubin. Bilirubin that is conjugated with glucuronic acid, example bilirubin diglucuronide, bilirubin monoglucuronide are called conjugated bilirubin. Bilirubin that is not bound to glucuronic acid is called unconjugated bilirubin. This bilirubin binds to albumin for transport in circulation. Direct bilirubin cannot cross blood-brain barrier, so not toxic to brain. However, indirect bilirubin is toxic to brain at high concentration as it can cross blood-brain barrier and cause kernicterus. Direct bilirubin is water soluble. Indirect bilirubin is fat soluble. Direct bilirubin can be excreted out of the body easily. Indirect bilirubin cannot be excreted out unless it is transformed to a soluble product. Causes of pathological jaundice. It is divided into two categories: unconjugated hyperbilirubinemia and conjugated hyperbilirubinemia. Unconjugated hyperbilirubinemia means increase in unconjugated bilirubin. That is, if direct bilirubin is less than 2 mg per deciliter and less than 20% of total serum bilirubin. Conjugated hyperbilirubinemia means increase in conjugated bilirubin, that is direct bilirubin fraction is more than 20% of total serum bilirubin or more than 2 mg per deciliter. Unconjugated hyperbilirubinemia may occur due to hemolytic cause, that is due to excess RBC breakdown, or may occur due to non-hemolytic causes, that is decrease in conjugation. Conjugated hyperbilirubinemia may occur due to hepatic causes, that is disease of hepatocyte or liver, or may be due to post-hepatic causes, that is due to obstruction at post-hepatic level. Out of these four categories, we will discuss one by one. First is hemolytic causes. Hemolytic causes of unconjugated hyperbilirubinemia. First is HDN, hemolytic disease of newborn. Example, RH incompatibility, ABO incompatibility and other minor blood group incompatibilities. Second is congenital or hereditary hemolytic disease, which is due to either biochemical defect in RBC, example G6PD deficiency, pyruvate kinase deficiency, hexokinase deficiency. Due to structural defect in RBC, example spherocytosis, elliptocytosis, pycnocytosis, etc. or due to defect in hemoglobin, example alpha thalassemia. Next hemolytic cause is hematoma or concealed hemorrhage. Under this category, cephalhematoma, subgaleal hematoma, other birth trauma, intraventricular hemorrhage or IVH, gastrointestinal bleed, etc. One more hemolytic cause is polycythemia when hematocrit is more than 65. That is increase in RBC number that occurs in IUGR baby or in infant of diabetic mother. Fifth cause is excess of injection vitamin K. It can also cause hemolysis and unconjugated hyperbilirubinemia. Sixth cause is delayed cord clamping. It can pull in more RBC, leading to more RBC destruction and jaundice. Seventh cause is sepsis and DIC. It can cause indirect bilirubinemia due to hemolysis of RBC. Eighth is TORCH infection. TORCH stands for Toxoplasma, syphilis, rubella, cytomegalovirus and hepatitis B infection. Let us discuss some conditions that lead to non-hemolytic causes. Non-hemolytic unconjugated hyperbilirubinemia causes are breast milk jaundice, hypothyroidism, Crigler-Najjar syndrome type 1, type 2, Gilbert syndrome, congenital hypertrophic pyloric stenosis, birth asphyxia, etc. These lead to unconjugated hyperbilirubinemia without any hemolysis. What are hepatic and post-hepatic causes? Hepatic causes for conjugated hyperbilirubinemia. Few conditions under hepatic causes are listed below. Idiopathic neonatal hepatitis, hepatitis due to congenital infection, example TORCH, hepatitis B, sepsis, etc. Inborn error of metabolism can cause congenital hyperbilirubinemia. Example tyrosinemia, alpha-1 antitrypsin deficiency, glycogen storage disease, hereditary fructose intolerance. Then next is total parenteral nutrition, intrahepatic bile duct hypoplasia. These are few causes that lead to hepatic increase in conjugated hyperbilirubinemia. Now come to post-hepatic causes for conjugated hyperbilirubinemia. One important cause here is congenital biliary atresia or EHBA, that is extrahepatic biliary atresia. Second is choledochal cyst. This is also one more extrahepatic cause. Breast milk versus breastfeeding jaundice. Breast milk jaundice and breastfeeding jaundice are often found to be causing neonatal jaundice. Both sound similar but are completely different. Breastfeeding jaundice occurs due to reduced breast milk intake by the baby, and breast milk jaundice happens due to presence of some factors in the breast milk that hampers conjugation of bilirubin. We will discuss in detail about breastfeeding and breast milk jaundice in another video. To sum up, 8 most common causes leading to neonatal jaundice are physiological jaundice, breastfeeding jaundice, cephalhematoma, prematurity or preterm baby, infection, example sepsis, TORCH, etc., blood group incompatibility, example RH, ABO incompatibility, breast milk jaundice, G6PD deficiency. Question time. Today's MCQ. It is called pathological jaundice if jaundice appears less than 24 hours of birth, jaundice developing more than 2 weeks in a term baby and more than 3 weeks in a preterm baby, rise in serum bilirubin of more than 5 mg per deciliter per day or more than 0.2 mg per deciliter per hour, all of the above. Write your answer in comment box below. Thank you for watching today's video. If you really liked it, then hit the like button, share this video with your friends and do subscribe to Pediatrics Simplified. Disclaimer, this video is for educational purpose only. For medical advice, kindly consult your physician.